Hello and welcome to Understanding Tardive Dyskinesia, brought to you by the Anxiety and Depression Association of America. And in this webinar, we are focusing on a significant health issue of tardive dyskinesia. Tardive dyskinesia, also known as TD, is a neurological condition often associated with long-term use of certain medications used to treat mental health conditions. TD can cause involuntary movements of the face, tongue, and other body parts. Understanding TD is crucial because it affects individuals who may already be managing mental health challenges. By increasing awareness and knowledge, we aim to reduce stigma, improve diagnosis, and enhance the quality of life for those who are affected. Joining us today is an expert in the field, Dr. Stephen Saklad. Dr. Saklad is a professor at the University of Texas at Austin, a published researcher and principal investigator, among so many things. Dr. Saklad, we are thrilled to have you here with us today to share your expertise and help educate our members on TD. Thank you so much for being here.
Thank you very much for the nice introduction. Let me give you a couple more things that are going on now. I've just recently retired from the University of Texas and now an emeritus professor. So I'm spending a bit more of my time doing a variety of consulting things and programs like this, because this is very important for people to be able to understand and apply to their routine practice. Tardive dyskinesia is one of the things that I've worked on throughout my entire career. The problem with tardive dyskinesia was first identified in the 19 really 50s, shortly after the antipsychotics were first developed, and it became a very prominent problem in the 1960s and 70s, and was a focus of a lawsuit in Texas where the federal government actually took over the entire mental health system because of a lack of sufficient monitoring for tardive dyskinesia. So this has been a big focus of my career. The problem of tardive dyskinesia has been with us a long time, and the original antipsychotics caused this at a very high rate, and we can get into that a little bit more later. Professional education on tardive dyskinesia was the major focus of learning about schizophrenia, and that was the source of where we get the name antipsychotics. They're now, of course, used for a variety of other disorders because we know they're really quite functionally improving people's lives. So they're used much more widely now. But the original antipsychotics, which are much less commonly used than they used to be, still an important part of treatment in some patients, these drugs cause about 30% of the patients to have tardive dyskinesia over time. Later in the 1980s, we developed a series of other antipsychotics that are called the second generation or atypical antipsychotics. And these newer drugs are considerably less likely to cause tardive dyskinesia and other Parkinson-like features as well early on, and tardive dyskinesia later. And because of that, the emphasis in professional education on teaching about and recognizing tardive dyskinesia has faded into the background. At the same time, because these newer drugs were so much safer, the areas they can be used in and the number of people that benefit from them has greatly expanded. Now, fully half of all the drugs that we used to call antipsychotics and now are more correctly called dopamine receptor modulators or blockers, these drugs are used 50% of the time for non-psychotic reasons. So this is a very important change. So it's very important for people who are treating patients now to have a very good understanding, once again, of tardive dyskinesia, not because the drugs we're using are necessarily bad and causing more of it like it was before, but now the drugs are used so much more widely that there's more people using it, and there's a wider variety of professionals that are providing this excellent care to their patients. So learning about that is extremely important. The most important thing we know about awareness is talking about it. So we need to make sure that we keep this as a conversation point when we're talking to our colleagues, when we're talking to professional audiences, when we're talking to lay audiences in particular. It's important that people know about tardive dyskinesia, that they be warned about it before they get the drugs, so they have an informed consent to taking the medication. And they also need to be monitored for the potential appearance of tardive dyskinesia. We know that very early on, sometimes it'll reverse itself. And other times we need to do something different to treat it, which we are now able to do quite effectively. But one of the important things to realize is that you need to monitor for it. And that is something that we need to learn how to do. So people with a variety of illnesses that never really had a reason to be monitored for movement disorders before, people with anxiety, people with depression, people with obsessive compulsive disorders, post-traumatic stress disorders in some cases, a variety of other illnesses that are usually considered severe illnesses but not requiring antipsychotic treatment, but these people need to be monitored as well. The impact on patients can be thought of in a number of spheres. One of them is their actual movements, that these are movements that interfere with their activities of daily living. They generally are repetitive motions that they don't find to be part of normal routine things that they would be doing. So they might have almost anything besides a tremor. Some people think of it as sort of like a tic where you have a large movement. It could be a repetitive movement of having your jaw move. Now, interestingly, your jaw moves in both a up and down kind of fashion, as well as a lateral fashion. Now, tardive dyskinesia frequently causes lateral jaw movements, and those are not a common feature of eating or talking. You only do that when you have something caught in your teeth and you kind of just move it around, unless you're a shark, because sharks eat that way. But it's important that people recognize these movements. An increase in your eye blink rate, an increase in a variety of motions, and the face is talked about a lot and monitored closely, mostly because we see your face very easily. Right now, you're looking mostly at my face, but you wouldn't necessarily notice that I had a variety of hand motions because you can't see them. So a lot of people will notice first their face, but sometimes it happens in people's feet. So one of the things you need to remember to do is to take the person's shoes and socks off so you can watch their feet. And you can sometimes have what's called piano playing fingers, where you'll just have this kind of emotion. That's not that bad for a few seconds, but if you're doing that anytime you're not paying attention, it becomes very annoying. Now, that annoyance conveys to other people. So other people see you doing these strange motions and they begin to pay attention to them and wonder what's going on. And you notice that they're paying attention. So you begin to have a variety of social and work-related impacts where people, if you're perhaps in some kind of a profession where you're talking to people, a therapist of some kind, working in a store selling things, people don't want to go over to you if you have funny motions. Okay, people are just scared of things they don't understand. So if you explain it to them, they'll understand. It won't be as big a problem, actually. So that is one thing to tell people, is let them know you have a movement disorder, and it decreases the mystery. The second thing is, when you have these movements, you begin to withdraw socially. because you don't want to have to deal with all the repercussions. So some people don't keep going to work and they are now unable to work and they're disabled. Some people will stop going to social events because they're afraid of people staring at them. They won't go to restaurants anymore because the little kid across the way in the booth at the restaurant points at you and says, "What's that man doing?" So these things are very much a problem for the patients. So you have movements themselves, you have social implications of the movements, and you have functional damage to the person. So the person withdraws. If you withdraw, you get even more depressed, anxious, and isolated.
That sounds pretty all-encompassing.
Yes.
Are there any other diagnostic criteria that professionals should keep in mind for and look out for?
There's a variety of things. The main way we both treat, monitor, and diagnose people, as well as do studies, is with a standardized rating scale, the most common one of which, not the only one, but the most common one of which is the abnormal involuntary movement scale, which is very simple to learn how to do and takes about 10-15 minutes to perform. And it involves a variety of things, including distracting uh, uh, activities to get the person's mind to not focus on suppressing the movements so you can see them. So a common one is to have person tap their fingers like this, and others are to count backwards from 10 or 100 or 52, and things that occupy the person's mind keep them from focusing on suppressing the movements. So that's an important feature that you have to do the exam. Also, just watching the person at rest is an important feature. So when I go to find somebody in a waiting room or a waiting area, I will just watch them for a couple of minutes, better longer, but a couple of minutes, just to see how they're doing. And it's important to have your staff looking for these movements because they might notice something funny and let you know, I noticed they have a funny motion in their hand frequently. So okay, my level of awareness has moved up, and now I might do a formal exam, whereas I might just screen them. And these exams are important. So in the state of Texas, they're actually required every 6 months for if you're an inpatient facility, or an outpatient every 6 months. Nationally, the American Psychiatric Association's guidance on this, which would be the national standard, is every 6 months you need to do a formal exam, which means doing the AIMS exam and writing it down in your records, and informally at every visit. So you're just screening the person for anything unusual. And as I said, I warn people when I give them the drug. And then every visit, I ask them if they've noticed any abnormal movements, or has anybody mentioned any abnormal movements you might have to you. Frequently, people will not notice something themselves, but they'll notice that somebody has mentioned that I have a funny habit with my hands. Some of my patients have acquired a habit of chewing gum, which is a good mask for chewing motions. So you get this back and forth kind of behavioral adjustment to take care of the problem. So anything new like that deserves your attention. From the older drugs, it's about 30% of people who are exposed for a period of 2 months or more. And the longer you're exposed, the higher the dose. The people with mood disorders, more than schizophrenic or psychotic disorders, are more likely. As I said, the older you are, so people who are older tend to wind up being exposed longer because they have the illness longer they need to be treated for. Women are at a higher rate than men in general, but that's accounted for by the fact that women are generally put on very same or similar doses, yet have a smaller body size, so they effectively have a larger dose than men do. Estrogen is protective, so women who go through menopause have a higher rate, but also they're older, so it gets very confusing. So all of these things increase the rate, but basically higher dose for longer is increasing your risk. And the original drugs, again, about 30%. Now, the newer drugs are frequently also mixed up with the older drugs in many patients, almost everybody you ever see. So when you look at the people who are on a history of both, it's about 20%. When you look at people, rare people, who are only exposed to the newer drugs, it's about 7.5%. So it's much lower if you can stay only on these newer agents. And all of this data is developing, and we're learning more every day. So there are new articles about this. For my lectures I do with my students on tardive dyskinesia, I have to update them every year with about a third new articles. So this is an evolving area that requires a lot of patience in reviewing the literature. Well, some of it is just epidemiologic kinds of things. That's where much of this has really occurred, is to understand who it is, what it is. That's where we know the data about 30% versus 20 versus 7.5. These are recent epidemiologic surveys. The advent of these large computerized databases that goes along with all those stupid forms everybody has to fill out and sign to release information. All of that can be anonymized, so it's not identified with anybody, but we can now start to connect the dots. I have access to a database that has close to, actually a little over now, 100 million people in it, and around the world. And this 100 million people allows us to go in and do little pointed surveys of how many people were on this drug and then had this report of a problem later. That is not able to show cause and effect. It shows an association. Just because people who took tests on Friday did worse than people who took tests on Wednesday doesn't mean it was Wednesday versus Friday. It could be that the person studied longer that had tests on Friday. So you have associations. You have to go back and do an experiment where you control the conditions, and then you can see what's causing it. So we've done these controlled experiments with some newly developed agents that are able to act on parts of the neuronal system in your brain that regulate movements. And some of these they have a whole bunch of names, and I could go into them in excruciating detail with slides, but I'll just give you a few of them. The dopamine receptors are in the basal ganglia area of your brain, in the middle of your brain. So if you look between my fingers and straight down from the top of my head, the area where they would all cross is an area that controls movement, as opposed to the forebrain, where you have executive decision making, and along the sides where you have movement and sight in the back. So when you're looking at these newer drugs, they're able to target specific areas they work in because of subtle differences in these different receptors. So there are dopamine receptors in 4 different areas of the brain, but the ones we're able to target for this are pretty specifically in the basal ganglia, and we modulate one of the little pumps that moves the dopamine around and is able to block the action of these little pumps, called VMAT2, and it decreases the amount of output of dopamine in these areas and decreases the overstimulation of the basal ganglia by dopamine that is the cause of tardive dyskinesia. Now, the cause of that is because of the dopamine blockade of the antipsychotics on these receptors, which is much more general. We're not targeting those receptors specifically, but they get hit as a side effect, literally a side effect, of the targeted area. And because we've blocked these receptors in some areas, the receptors go, I haven't got a signal, so I need to put up more antennas, a bigger antenna, grow more receptors so I can detect the signal. So you grow more and more receptors, and eventually that creates a bigger output of that area in your basal ganglia, and you wind up with tardive dyskinesia. So by decreasing the amount of dopamine being released in this area, we can decrease the tardive dyskinesia. So these new drugs that have really been developed in just the past few years are a gigantic innovation in psychiatry and for patient care. Now, because they're new, they're also very expensive, but the pharma companies that produce them, which have spent a fortune developing these drugs, so it goes together, but not directly, they have a lot of patient assistance programs. So if your insurance doesn't cover it or you can't afford it, they will generally provide the drug at greatly subsidized cost or free. Generally, these are something that you could do a search for tardive dyskinesia or VMAT2 inhibitors, and they will point you at websites that generally will find their way to these product websites. The product websites have also patient assistance websites, and you can go click on those from either of the two companies that produce these products currently, and it's fairly easy to find that. Really, the VMAT2 inhibitors are the gold standard now. They are the recommended treatment in the American Psychiatric Association's guidelines from 2019 for schizophrenia, which is the most recent, and also in the American Academy of Neurology guidelines. All of these guidelines and a variety of others, some of which I've had input in, which means I've had that much input. Some of these are all recommending this when they're updated. Some of them have not yet been updated. But generally, this is the gold standard. There are a number of other things that have been tried. They have marginal at best evidence for efficacy. Of course, if it works for you, it works for you. But the VMAT2 inhibitors work for the large majority of people. I had a case just last week that the patient didn't respond. So that's where you need to move to an expert review, make sure that it's actually tardive dyskinesia, not something else. And you need to then go to more innovative expert interventions that can involve that the patient didn't respond. So that's where you need to move to an expert review, make sure that it's actually tardive dyskinesia, not something else. And you need to then go to more innovative expert interventions that can involve things like going out of the usual dosage range, or sometimes, not in this case, but in some cases, combinations of medications, or adjusting for drug interactions. So there's a variety of important things that you can do, even for people who fail on these new gold standard drugs. But there's a lot of research on these. In fact, just this past year, one of these two products went from being required to be given twice a day to once a day. It's important for any healthcare provider of any kind to be monitoring all of their patients receiving any kind of a dopamine blocking drug, because they could develop tardive dyskinesia. So it's very important they be monitored. They should be monitored casually at every visit and systematically with a tool like the Ames exam at every 6-month interval. The other thing is to know that you should inform patients about tardive dyskinesia before any of these dopamine receptor blocking drugs are given. There are other indications for these dopamine receptor blocking drugs than psychosis or schizophrenia. For example, depression, severe anxiety, obsessive compulsive disorder in some cases, bipolar disorder. All of these are important uses of these drugs, including GI problems where we use dopamine receptor blocking agents as well. So all of these things are important. It's important to recognize that tardive dyskinesia is not a problem that is now gone. This is a problem that's still with us, but much less common than it used to be. It's important to recognize that we have highly effective and well-tolerated treatments for people afflicted with tardive dyskinesia. Most people with tardive dyskinesia can be greatly helped. I can improve the social interactions, the movements, and the function of the people with tardive dyskinesia with these new VMAT2 inhibitor agents. Giving people hope is extremely important.
Dr. Saklad, thank you so much for joining us today and for sharing your expertise. We
I'm
know that
very happy to help out.
this will be of many help to many of our members to help them better understand the condition as they continue their lifelong learning and professional development.
Thank you for the opportunity again. It's been a pleasure.